Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars I'm organizing as second vice president of the World Federation of Neurosurgical Societies, the WFNS, in collaboration with the Egyptian Society of Neurological Surgeons, the ESNS, and the Continental Association of African Neurosurgical Societies, the CANSO. Important to tell you that we already organized 46 webinars since the start of the COVID-19 pandemic. 15 of them are educational WFNS symposia. Today is webinar number 47, and it is organized in collaboration with the Neurotraumatology Committee of the World Federation of Neurosurgical Societies. In this occasion, I would like to thank Professor Tariq Khan, Chairman of the Neurotraumatology Committee of the World Federation of Neurosurgical Societies, for supporting the organization of this event. And actually, I'm honored by such collaboration. Let me welcome all our distinguished speakers. I will go by the order by which they speak. Professor Russell Andrews is a well-known, eminent neurosurgeon. He's affiliated to the Department of Neurosurgery, Good Samaritan Hospital, San Jose, California, USA, and he is consultant in the NASA. Professor Iko Parasitio, he is head of the Neuroscience Department, Centra Medica Hospital International, North Minahasa, Indonesia. Professor Maximilian Mehdorn, he is former chairman of the Department of Neurosurgery, University of Kiel, Germany. Professor Virendra Sinha, he is affiliated to the Department of Neurosurgery in Jaipur, India, and he is chairman of the Neuro Rehabilitation and Reconstructive Neurosurgery Committee of the World Federation of Neurosurgical Societies. And Professor Tariq Khan, he is dean and chairman of neurosurgery at Northwest School of Medicine, Peshawar, Pakistan, and he is chairman of the Neuro Traumatology Committee of the World Federation of Neurosurgical Societies. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. As second vice president of the World Federation of Neurosurgical Societies, I understand that one of the most important missions of our organization is to promote educational activities among all young neurosurgeons, especially in the developing countries. Today program, we have 5 very important topics and very interesting. The first talk will be novel technologies for neurotrauma and mass casualties by Professor Russell. The second talk will be traumatic brain injury and neuroplasticity by Professor Iko. The third topic will be neuro rehabilitation in neurotrauma, Professor Mehdorn. And the fourth topic will be pre-hospital guidelines in lower and lower middle income countries, Professor Sinha. And then again, neurotrauma care in the low and lower middle income countries by Professor Tariq Khan. Until yesterday, we have 332 registrants over Zoom. They are going to participate in this meeting. We are also doing a live stream over the Facebook page of the CANS, and this is the address, and over the YouTube channel of the Egyptian Society, and over the Neurosurgical TV. And in this occasion, I would like also to thank John Bennett, who is doing live stream of this event over the Neurosurgical TV, and actually is doing a very good job in promoting our series of webinars. Our series of webinars usually is followed by thousands of our colleagues from different continents. To all attendees, we are glad to get all your questions and comments, and it will be monitored through the chat panel or the Q&A. We are also offering certificates which you can print electronically, but just please allow a few weeks after the meeting in order to give a chance for the organizing committee to upload all the emails to our system. This is the link by which you are going to print your certificate electronically. The username is going to be the email by which you register to this event, and this is the password. Next Friday at the usual time, it's going to be actually on 24th July. It's going to be Saturday at 2 p.m. Our webinar, which is webinar number 48, is done in collaboration with Professor Lucas Razolik. He is chairman of the Peripheral Nerve Surgery Committee of the World Federation of Neurosurgical Societies, and we have 9 eminent speakers. Important to tell you also that I am organizing the Third Man's Congress, which will be held in Egypt, 27 October, but it was supposed to take place this year. However, due to the COVID-19 pandemic, it's postponed to the next year. It will take place in October 27 to 30 October 2022. I am the president of this Congress, and Professor Alberto De Letala is president of the Mediterranean Association of Neurological Surgeons. All of you are invited to participate in this important event, and I think it will be a good chance to visit together the Grand Egyptian Museum. Thank you very much for attention, and now I will give the talk to Professor Tariq Khan. He is the chairman of the Neurotraumatology Committee, the World Federation of Neurosurgical Societies, to say his welcome note. And I think Professor Mahmoud Khorashi just sent me a message now that he already joined, and he will be pleased to say a welcome note. He is president of the CANS. Thank you very much.
Thank you, Nasser. Hello, everybody. Welcome to this very important webinar, which is a joint collaboration between the Egyptian Society of Neurosurgeons and the Continental Association of African Research Societies and the Neurotraumatology Committee of WFNS. I would like to thank Professor Nasser and his team for organizing this wonderful webinar, and I hope that the young neurosurgeons will be able to learn from the experiences of everybody here. Thank you very much.
Thank you, Professor Tariq Khan. Professor Mahmoud Khorashi.
Thank you very much, Professor Nasser. It's always a pleasure joining your webinars that you do on behalf of the Continental Association. And on behalf of all the young neurosurgeons and all the member societies of CANS across the continent, I bring you their greetings and their gratitude for involving everyone globally to participate in this educational activity. It's a pleasure to see friends online. We've got Russ there. Hi, Russ, Tariq, Virendra, Maximilian. It's so nice to see you virtually. Hopefully this will end and we will meet once again. And nice to make your acquaintance, Professor Echo. And Hassan, you're always there in the webinars. So great to see everyone. And once again, a pleasure joining such illustrious colleagues. And I'm looking forward to the educational bonanza that's about to be unleashed by Tariq Khan.
Thank you. Thank you very much, Mahmoud, for these kind words. And now it's time to start our scientific sessions. The moderator of this symposium will be Professor Tariq Khan and myself, and we will have discussion at the end of each talk for a few minutes, and at the end of the webinar, we will have open discussion among all panel. May I invite our first speaker, Professor Andrews Russell, to say his important talk, which is going to be novel technologies for neurotrauma and mass casualties.
Okay, I will be sharing my screen, and this is narrated, so I will start it, and then we can discuss later. Oops, let's go back to the beginning here.
Welcome from California.
We'll be discussing how technology can improve global surgery and help us achieve the UN healthcare-related sustainable development goals for 2030. SDG 3 is the one related to healthcare. On the bottom, we can see that high quality healthcare is necessary for a number of disorders, the top 6, 4 of which surgery is essential for diagnosis and treatment. 1/3 of all deaths worldwide are due to lack of surgery. This is more than 4 times the deaths due to HIV, AIDS, tuberculosis, and malaria combined. We can see the GDP loss due to trauma and neoplasm alone will exceed cumulatively more than $12 trillion by 2030, and already in 2021 is costing more than $500 billion. Walt Johnson, former lead for emergency and essential surgical care at WHO, noted that more than $400 billion should be spent over 15 years to bring low-income countries up to middle-income standards. But if we don't do this, the cost will be greater than $12 trillion, or more than 20 times as much. Surgery is an investment, not a cost. Natural disasters, as you see in the upper right, earthquakes alone could kill over 200,000 people in some years. The cost of natural disasters, $500 billion, with 26 million people being forced into poverty, but there are also unnatural or man-made disasters, infrastructure failures, transportation accidents, terrorism and warfare. And so there are years where the total number of deaths due to disasters is greater than 400,000 people. It's recently been noted that we really need to start aligning our surgical and disaster planning. Mass casualty disasters present an opportunity, however, in that countries that may not communicate surgically, socially, or politically will collaborate to respond to a disaster. So how can we leverage this to improve day-to-day care as well? Trauma stroke centers present the model of full integration in the healthcare system and covering every aspect of healthcare from prevention to care, acute and rehabilitation, as well as education and training. Examples of benefit in trauma, being transferred to a non-trauma center rather than a trauma center, 30% increase in mortality in the first 48 hours. National study in Finland on stroke, comprehensive stroke center versus a general hospital is much lower case fatality rate and a much higher incidence of people being at home rather than institution at a year. Characteristics of mass casualty center, you transfer to the site within 12 to 24 hours rather than days to a week as it is presently. Full integration in underserved regions, stable government, combination of developed and developing country staff. But again, the benefit being healthcare resources, day-to-day basis for the region. So the benefits, when you have a radiology department, intensive care, blood bank, you can deal with situations like complicated childbirth, acute abdomen, 24/7, 365. And combining with the military provides emergency care that they are now using as training exercises. We mentioned camaraderie, but the standardization worldwide for research and medical education is a real benefit. Helps us meet these goals of the international organizations. I'll focus in on military and civilian collaboration. Militaries are usually the best equipped for emergency response in a country. And in the US, there's efforts now to establish a national trauma system combining the resources of military and civilian response. The cost of violence is 1/10 of global GDP presently. And in the US, nearly 1/2 of all deaths of those under age 50 are due to trauma. The map shows in red the high incidence of trauma deaths, and in blue where you're within 1 hour trauma center. So where you live may determine whether you live following. And there's certainly good evidence of this. Here from Afghanistan, Secretary Gates' Golden Hour policy, they reduced the pre-hospital time from 90 to 43 minutes, and this reduced the case fatality rate by about roughly 50% as well. Another reason for combining the military and civilian resources, the civilian sector has a fairly constant patient volume, whereas the military sector very much influenced by warfare and conflict. Infrastructure is susceptible to disasters, both the buildings and with flooding. And thus, we may be necessary to bring everything in, including the personnel, and thus telemedicine is a crucial aspect of this. Looking at the concept of twinning between developing and developed nations, primary example is American College of Surgeons pairing with these various institutions in the US and Hawassa University in Ethiopia. There are a number of neurosurgical twinning programs, Henry Ford Hospital and University of Bern in Switzerland, twinning with Yangon General Hospital in Myanmar, in Uganda, Duke University, and Stanford to a lesser degree is paired with the Ugandan healthcare system for neurosurgical. Some of the technology available, surgery in a backpack, you can actually, don't need an operating room. Battery-powered CT scanners that are mobile. This has allowed a stroke ER on wheels in various countries. And you can have a CT in your mobile operating room. Robots can benefit disaster relief. One aspect of these imaging intensive drones, thermal imaging, for example, can detect humans under a collapsed building. Smartphones are a real resource. Cesario allows a person who's had a seizure to be identified by emergency department as well as family members and rescue them as quickly as possible using the GPS capabilities. Smartphones are being used in Kenya to improve maternal and newborn health services. In the upper right, you can see that a drone can deliver a defibrillator in many situations faster than an ambulance, and the bystander follows the simple instructions to provide defibrillation. In the bottom right, Good Sam is combining drones and smartphone apps in the UK to work with the NHS there. Drones could also deliver products such as vaccines and lab specimens. They've been used now for close to 5 years in Rwanda, with 2 sites really covering this small country. This has expanded to India and other countries, and in the last year has been used for delivery of COVID vaccine supplies in the US in remote areas. And once they get involved with companies like Amazon and Walmart, drone delivery will take off. Another aspect, telemedicine plus smart glasses. Our colleagues in Malaysia put PPE on one of their neurosurgery residents with the smart glasses. And this individual is making rounds in the ICU on the COVID patients, avoiding the rest of the staff having to participate in direct contact. So we see that you can combine the smart drones and smart glasses to get smart disaster triage. An individual can direct the resources on a minute-by-minute basis to optimal utilization. Telemedicine's also been used by groups like the NATO, the National North Atlantic Treaty Organization, thanks to Rafat Latifi, and also for countrywide neurotrauma response by establishing such a system. The reduction in the number of transfers of patients more than pays for the telemedicine system itself. And going a step further, we can have a digital operating room, which can really make distance not a problem. You can assist a surgeon anywhere with this sort of technology. You can see this was started by one of the 50 women changing the world. And it really just is limited by our imagination, how we can use everything from augmented reality and artificial intelligence to support surgery globally. Returning to the Mass Casualty Center project, 2 sites in northwest Pakistan in Peshawar and northern Chile in Iquique. Thanks to Sergio Aguilera, in Chile. He arranged a meeting in Iquique with the healthcare representatives, the Air Force Base there, and ONEMI, which is a Chilean Emergency Response Ministry. And a year later, we met with the chief of the Naval Hospital, which is a primary military tertiary facility, about communicating with the civilian sector. Similar meetings have been held with military in Pakistan to unite civilian and military resources. Tariq Khan has done a rather amazing job in Pakistan, opening 2 hospitals, a nursing school, a medical school, and coordinating with their national vision for surgical care over the last couple of years. Pakistan is the one non-sub-Saharan African country to have an NSOP, or National Surgical Obstetric and Anesthesia Plan. You can see the goals for 2030 on the right there. And so summary of the Mass Casualty Center project is basically integrating all these resources and using such collaboration to improve not only mass casualty response, but day-to-day healthcare worldwide. If you're interested, some recent publications. This is a recent publication from the Journal of the American Medical Association Health Forum. You'll notice that Jeffrey Rosenfeld is a fellow neurosurgeon, but Nigel Crisp was the CEO of the National Health Service in the UK. And since his leaving that post, he has devoted himself to cost-effective healthcare techniques learned from developing countries. The point is, we really should get out of our neurosurgical silo, not only in neurotrauma, but neurosurgery in general, and work closely with our surgical colleagues, as well as anesthesia, intensive care, rehabilitation, injury prevention, all aspects of healthcare, including the hospital administrators and the ministries of health. This is the way we're going to really expand not only neurosurgical care, neurotrauma care, but surgical care in general, and help us reach the UN SDG number 3 for 2030. And finally, I'd like to thank the real prime movers in this project. On the upper left, you have Tariq Khan in Peshawar in his traditional Pashtun headdress. Next to that is Leo Quintana and his wife Susana and son Felipe in Valparaiso, Chile. Below that on the right is Sergio Aguilera, also from Chile, and myself. And in the bottom left is the opening ceremony for Tariq Khan's first hospital in Peshawar in 2009. With that, thank you very much.
Thank you.
Thank you.
Thank you, Russ, for excellent talk on a lot of innovations in the future, how to improve things, especially about having people able to operate at a distance and be seen and be guided by everybody. So any comments from the panelists or from any questions from the participants? Okay, so shall we move on to the next thing? Thank you very much, Russ. Next talk is by our friend Iko Parestu, and he's going to talk about TBI and neuroplasticity. Dr. Iko?
Can you see my slide? Right?
Yes, thank you.
Thank you, Professor Tariq, Professor Nasir, and all members of Neurotrauma Committee, WNS. So in this event, it's how wonderful to join in this meeting. No disclosure. Until a few decades ago, the neuroscientific dogma on the unchangeable human nervous system was common except for degenerative processes. TBI and neuroplasticity is an infinite journey, as like as we explore the universe. The term of neuroplasticity was already used by the father of neuroscience, Santiago Ramon y Cajal, who described non-pathologic change in the structure of adult brain. Kramer et al. Neuroplasticity has been defined the ability of the nervous system to respond to intrinsic and extrinsic stimuli by reorganized connectivity, structure, and function. Wheelock and Nikolic presented pathomechanism of neuroplasticity are cell function and neuroanatomy repair. JC and Watt described that the neuroplasticity was component of neuroprotective and neuroregenerative. Meanwhile, we remind that neuroinflammation is the key factor of pathomechanism of secondary TBI. It's clear that neuroinflammation is a process that must be overcome in order for the neuroplasticity processes to take place properly. Let me see the slide. It's clear how the neuroinflammation important is. As we review in any journal. And as we know, neuroplasticity has been studied simultaneously in secondary TBI. NVU or neurovascular unit is targeting place in brain insult. The location of damage to brain tissue actually start from a complicated process that occurs in the NVU or rather the blood barrier or the extracellular matrix or ECM. One of those elements is blood-brain barrier. Interconnection of NVU is an important link to support neuroplasticity. A few decades ago, paradigm of neuroplasticity stated that switching important roles from neuron to matrix. There are three level scale of network brain organization. Micro scale, the level of individual neuron and synapses. Meso scale, the level of neural group and population. And macro scale, the level of anatomical region and interregion pathways. How to support neuroplasticity and TBI. So the important is how to key restore brain homeostasis, create an optimal microenvironment. There is a link to support, as we said, protein, signal, and ECM or blood-brain barrier. Where, as another side, the brain is the high energy organ. The majority signal used for protein kinase cascade. Kinase cascade mostly affect in MBP9 signal with a modulator nuclear kappa beta during transcription and translation level. As we note, the start after neural damage, DMPS or damage molecular associated protein pattern and high MGB1 or high mobility group box 1 are stimulate initial process of neuroinflammation or microglia polarization. Our colleagues in Indonesia have researched and published that describe HMG1 is one potent modulator in these processes. NVU or blood-brain barrier is entry point to all of this mechanism. And we had published our research that protein component of NVU, which we call laminin, is a material of NVU or ECM that improve the outcome of TBI. As we stated earlier, that neuroinflammatory process is important part of brain damage. In that process, it's known that microglia are resident glial cell that are free influential in neuronal inflammatory process. And there are two types of microglia, which we perform as the good and the bad. There are two phenotypes, microglia M1 to M2. M1 acts as pro-inflammatory control, and otherwise M2 is an anti-inflammatory or brain recovery repair support. Clinical aspect. TBI are multifactorial and pathway. So we need golden bullet or bulk therapy. The golden bullet in treatment of acute TBI is not yet determined. While in the past decade, our understanding of cellular and molecular change that occur after TBI has significantly increased. A number of new potential therapeutic targets has been identified that enable prevention of the onset of reduction of the extent of secondary TBI. One research said, is it EPO is golden bullet? Yes, surgical and non-surgical approach we need to treat TBI. Flaw and handicap in clinical research. Despite this limitation, the potential to pharmacological stimulate neuroplasticity and thereby promote recovery after TBI is too interesting to ignore and will continue to be explored. We describe this: inadequate understanding secondary TBI, insufficient preclinical testing in multiple model, lack of true investigation, pharmacokinetic, concentration drug investigation, lack animal model, heterogeneous patient population, inadequate sample size, lack of power, and adequate functional outcome measurement. There are several studies showing neuropharmacological treatment for TBI, such as PRR or minocycline. And our colleagues in Indonesia and France present and published that MLC 901 could be decreases increasing neurogenesis and inhibit neuroinflammation. MLC1 is Chinese traditional medicine. And the caffeic acid phenyl ester proved by our colleagues in Indonesia that decreased neutropil level in mice in TBI. Harnessing of neuroplasticity, modern approach and clinical future. So you can see many protein. We use research in neuroplasticity, and for the next change, immunization. Also, hypothermic therapy, DBS, repetitive transcranial magnetic stimulation. As we mentioned before that the brain is a high energy organ. Hypothermia, even though it's still pro and controversial, set a prospect to explore further. The mechanism action of hypothermic therapy, yes, it's like a bulk therapy, which is expected to perform many pathways of TBI. We had published our research that hypothermia could reduce mortality in severe TBI. As like thermotherapy, hyperbaric oxygen therapy, which is expected to be mainstay like hypothermia as a bulk therapy and TBI. We just published our research had concluded that hypothermia, hyperbaric decrease MPB1 and effectively to relieve post-concussion syndrome. The research is still going on for the other cases. Park et al. Review efficacy of the all-in-one therapeutic strategies for severe TBI, not only surgery, also pharmacology, neuropharmacology, and other modalities. As we know, we should be treated TBI in multidisciplinary approach. We keep still journey to the universe, this universe of neuroplasticity phenomena and mechanisms continue to expand, and multiple growing point associated with different areas of biochemistry, molecular biology, and molecular genetics are turning to powerful branches. A definite pathway with many mysteries. Research on TBI should be further encouraged and integrated. And the last, the take-home message, neuroplasticity and TBI, the key point is neuroinflammation with multiple pathway, the entry point and NVU, and the component of plasticity is neuroprotective and negative. Thank you very much. Bless you all. Thank you, Prof. Tariq.
Thank you very much, Professor Iko. Now we proceed to our next speaker, Professor Mehdorn is going to speak about neuro rehabilitation in trauma patients.
Can you see my slides?
Yes.
Perfect. Okay. Well, thank you very much for inviting me to participate in this very important and very interesting symposium this afternoon. And I have taken over the part of neurorehabilitation. We heard that neuroplasticity is extremely important, yet prevention, as you can see from this car accident or car imaging from Pakistan, prevention is better than therapy. Then follow all the neurosurgical therapy, and then neurorehabilitation is mandatory. So in order to, I would like to thank Professors El-Ghandour, Tariq Khan, and Mahmoud Qureshi. And I would also like to point out that I learned a lot from the occupational therapist Kashif Adalvi from South Africa, who is very enthusiastic, and we wanted to cooperate together and put up some good things, but we were not able to do so due to COVID pandemic. So the optimal path of a neurosurgical trauma patient should be from the acute car or whatever injury to optimal therapy, rehabilitation, and then bringing patient back into social reintegration as much as only possible. So these are the points I would like to mention. What is neurorehabilitation? What are its purposes? Patient's path going home, neurosurgery and neurorehabilitation, and then neurorehabilitation concerns in patients suffering from traumatic brain injury. I would like to point out that the major goals of neurorehabilitation are to enable the patient with the disabilities to perform again and show activities toward attractive aims, and reduce emotional burdens and show more activities again. So it's an ensuing circle which should continue over time. And not only the patients have major emotional burden, but also that's very important to note the relatives. To give support also to all patients with disabilities to arrange with a new situation, and to develop as much as possible a new kind of identity which is in contact with the past, but which also looks very much forward. So they have to cope with this. The results always need to be evaluated very carefully, and that's one of the studies follow up 2 years after discharge in a young population, which is rare in Europe nowadays. They stayed in the occupational rehabilitation for quite some time, but the results are really making it worthwhile. Prior to treatment, 70% were unable to work. After this treatment period, only 6% were unable to work. So there is improvement, as we heard from Professor Echo, due to the plasticity of the central nervous and peripheral nervous system, but which needs to be put into perspective, which needs to be worked on. Age, people are getting older. That's the main risk factor for disabilities. Persons like over 60 years old, there were 675 in 2005, 2050, 1.9 billion. Increase rate of older patients with old profound disabilities. And globally, only 3% of individuals who need rehabilitation really get it. There was a United Nations report in 2006 that 40% of the countries questioned did not have established rehabilitation programs. And I think that's very true also for African countries. So the background of neurorehabilitation in low-income countries, there is a lack of routinely collected data of disability and limited information about the needs of persons with deficits. Variability in definitions for different types of disability exists, and a different understanding of disabilities of politicians and healthcare management. On the macro level, policy and planning is necessary, infrastructure, resources, healthcare information systems, and all the others which are listed here above. So there are a lot of things to take care of. So as we heard from this plasticity, rehabilitation is a design of learning a situation, and neurorehabilitation is a design of situations to train the brain, spinal cord, and the peripheral nerves on their ability to improve, to become functionally as normal as possible. So from clinical to therapeutic to normal milieu with active integration of the family and also with spirituality. So the principle of hope is very, very important in the designing of learning situations. We have to bring the patient to really improve in this normal living. That's a very old story. Frankel in Germany, they started tried to improve on symptoms like training for walking on various grounds, which was one of the very first steps, and also work with these machines to improve on bilateral dexterity, to improve strength of both arms and so on and so on. Then 100 years later, the World Health Organization developed the International Classification of Functioning. So away from the symptoms, but more to the activities. So goal-oriented activities, body function and structures, environmental factors, personal factors, participation, they all should be centered toward improving the activities of a single patient. So traditional versus context-sensitive neurorehabilitation, traditional lesion-specific focus. Now it should be focused on all-day activities to develop a useful action, reasonable tests as dynamic evaluation. Retest is very, very important, not just to keep someone busy, but it's really important to learn how this patient improves and to bring up his possible future goals. Flexible target-oriented learning activities of daily living should be improved, oriented participation and activities, and this brings the need for more outpatients, so the patient should not stay so long in the rehabilitation unit, but get as rapidly intermittent also become outpatient again. And the entire team can participate in the narrative reconstruction of the self, emotion, and cognition as an early entity. So besides the ICF, there's also SMART strategy for the aims of neurorehabilitation, which should be specific, measurable, achievable. So don't bring up goals which cannot be achieved, but make reasonable goals. They should be relevant and they should also be timed according to the patient. And it's very important to treat a patient, not the symptoms. So the patient needs to be examined. And Kai Schäfer always points out very important that the residents very early on have to learn. That's why it's a teaching session here. They have to learn to examine the patient also with the course to have good examinations to teach them how to develop further, how the patient improves. And that's nicely shown here by this old publication in stroke, the time course and probability of walking 150 feet or more with assistance are shown for patients with motor deficits only, those with motor and sensory deficits, and those with sensory and visual deficits. So you see it's more complicated for a patient with motor, sensory, and visual deficits following stroke to improve on his function than for the one who has just only one deficit. Now, the organization of neurorehabilitation starts immediately after the injury to pick up the very early phase of the rehabilitation of the plasticity of the after the injury of the brain and the spinal cord. So it should start immediately after injury, respective surgery. It should start in the neurosurgical ICU. That's very important. And then neurosurgeon sends patient to the neurorehabilitation unit. And the patient comes back when complications occur. Hopefully they won't occur so awfully. And then the neurosurgeon should also care for the patients afterwards. So the question is, and that's a political question in many countries, where should neurorehabilitation units be located? And I think they should be located as closely to the neurosurgical units or to neurological hospitals as possible so that they have a good cooperation both together. And then the question also, hospital-based neurorehabilitation versus outpatient neurorehabilitation, probably a combination of both. And the major question certainly beside the organization, who would pay for the neurorehabilitation, particularly in low-income or middle-income countries? And this certainly needs to be discussed in an individual case, but I would think we should take care of the disease of the complete setup for the patient and combine acute therapy and rehabilitation and pay for all together. So make a bundle of it. In the neurosurgical ICU patient care monitoring, all these caring for the patient and the relatives, because they are very necessary, very important in the follow-up, and they should brought into understand through the environment. They should be allowed to come to the ICU as much as possible, and basal stimulation and should be very important. Basal stimulation, like not only the white wall or white carpet, but you should bring up information to the patient. And so he should get basal stimulation and also get some kind of music therapy or listen to the music which he likes and the scent and everything like this. So these are just only some examples. The patient, I mentioned very much, the grading is very important. The patient can be graded in the ICU with the early Bartle index, or later on he's graded according with the Bartle index of activities of daily living, from eating to control of bladder. And when he gets 100%, he becomes independent. That's the goal of every kind of treatment, also of neurorehabilitation. So in Germany, at least, we have a very rigid time frame, which is given by the insurance company's time frame of treatment. You see phase A through E, each is with maximum of 4 weeks, 8 weeks, and so on. But sometimes also it's realized that the patient cannot continue on rehabilitation, but then he goes into the long stay nursing care. So one example is a beautiful rehabilitation unit with whom we have been working, and a huge crowd of people working there, and they are dedicated and bringing everything, trying to improve for these patients and learn them how to work, how to behave, and speech and everything, and then facial movement, everything is discussed extensively, and you see fine movements. So it's very important. And then the course, what happens to the patient after he leaves the hospital or after he leaves the rehabilitation unit. So at the moment, very many of these hospitals are located in beautiful areas to also stimulate the patient, but it's also very important to have them as close as possibly to the acute hospitals. 6 years follow-up in more than 1,000 patients. In the phase B, the outcome is high age means certainly a higher risk of dying, which may be self-explanatory, but it's an ethical question. Should we take care of old patients in limited resource countries? Everyone has to answer this on his own. High points of GCS, respective Bartle index, reduced risk of dying within 5 years. Swallowing impairment, obligatory surveillance makes a poor ranking scale. Communication disorders also lead to reduced health-related quality of life, and percutaneous endoscopic gastroscopy is one part of this. Predictors of employment at 1 year: pre-injury employment status, level of education, etiology of the trauma, days of post-traumatic amnesia. We all know this, but it's very important also to remind that associated spinal cord injury is a predictor of employment outcome, functional independent measures at rehab discharge, and length of stay in the rehab. Obviously, I would like to just only show a little bit about spinal cord injury, neuro rehab paraplegia in a hospital in Hamburg, with whom we have been cooperating very much. That's a typical setup. And that's a question, a movie which I always like to show. In a young patient who came from Africa, and his mother came from Africa. He got a spinal cord injury fiddling around with his classmates, and then he got a tetraplegia. Now he's breathing. He's on the ventilator, not able to breathe. He's only moving his wheelchair with this mouthpiece. And so the question is, which country can really afford this? We are proud that we can do so, but we also anxious whether we can always perform this. And then we have another patient, and now he's a therapist in this hospital who came out from Africa and who teaches people because he was an active football player or basketball player rather. And then he had a car accident, became paraplegic, and now he's teaching he became employed of the hospital, and he's teaching these patients. That's a very sophisticated system, but we also can develop neurorehabilitation, or neurorehabilitation can be developed according to the possibilities, like in Pakistan and Peshawar. They had a beautiful setup, in which I like very much is saying, you see, they do all the setup for the wheelchair themselves instead of buying this in extensive companies, but I don't know why. So that's important. It's not our disabilities that count, but it's our abilities that count. That's very important as a take-home message. And you should try to improve on the abilities as much as possible and overcome the disabilities. Interaction between caregivers and patients. It's a client-centered approach. Gain contact to the patient, register his response, develop intentional interaction, and have him partially participate and make goal setting as reasonable as possible to have good clinical results, and also take care of the relatives of patients with severe brain injury so that they can further improve. So physiotherapy, ergotherapy, basal stimulation, then we have these invasive therapies like RTMS, transcranial magnetic stimulation, or then we have this invasive brain-machine interfaces, which are certainly at the moment everyone likes to talk about these, but it's needs to be evaluated very, very carefully whether we can do on these machines and who could really afford to get such a system. And it's a big discussion also in high income countries. Technological advances, robotic surgery, BMI, becoming more and more important, and also ethical legal issues, because we do not know really well how much the personality of a patient is influenced when he is attached to such a system, either to a robot or to a brain machine interface. But we have to know non-invasive alternatives as well. And that's the training on the virtual reality, as you can see, on various possibilities. And then we can offer the patient various kinds of exoskeletons so that he's able to walk again, to be guided with the system. And then the next step is put an implant, stimulation implant on the spinal cord below the level of injury. And there are good studies like coming from Switzerland, also from Germany and other countries, or put some electrodes on the brain, on the visual cortex, and get the patient see again, so he would be able to be able to drive a car, for example. What is very important, all these things can be very expensive, and so these devices need to be evaluated very, very carefully. And there was a study 3 years ago from Peru, and they found out that the overall, they studied 100 different commercial post-stroke rehabilitation devices offered via the internet. Only 1/3 of them had a randomized controlled study that had proved efficacy for rehabilitation purposes. So much money is wasted if you buy if you recommend such a system to your patients, which is not well evaluated. Very, very important. Human patient caregiver interaction is very important. Teleneurohabilitation, and we heard about this a little bit in the great talk of Professor Russell. Training on machines, robots for repetitive tasks. That's reality in our countries. Assistive strategies are very important. Computer control, as I told you, and brain-machine interfaces to train activity dependency and plasticity with all the legal points. So I think it's nearly over. No problem. Thank you very much for listening to this talk.
Thank you very much, Professor Maiden. Max, thank you for giving a talk on a most important aspect of patient management, which sadly is mostly missing in lower and middle income countries.
Right.
Our young rehab students in Peshawar still remember the wonderful course you and your team conducted on rehab. Thank you very much for that again.
So we'll come again if you wish.
Definitely, we would love to do that.
Important.
So, any comments from anybody? Or should we move? Yeah, please.
I think looking to this present situation in low-income countries and middle-income countries, we must stress on the basics of rehabilitations.
Right.
That is very important, and that makes a lot of difference. Yeah, and we must develop a model for these low-income countries and middle about the rehabilitation.
But we had been disturbed by a pandemic, and I hope that we can work together with Professor Qureshi and his team. He was very enthusiastic, very supportive when we had this meeting in Beijing in 2019, and hopefully, inshallah, we'll work together again.
Yes.
That certainly remains the agenda from a continental point of view, because as we noticed when we were in Beijing, just I know this is a global audience here, but speaking from a LMIC standpoint, there are a handful, literally a handful, or less than a handful of countries with rehabilitation services to speak of. And I think we noticed that during our discussion in Beijing, and the plan was to try and see how through the WFNS Committee of Neuro Rehabilitation to enhance that. And the agenda still remains open, and we look forward to that, Maximilian.
Perfect. Thanks.
Thank you. So can you stop sharing, please, Max? The screen?
I could, wait a second. Can you do it yourself? I stopped, sorry.
Maybe Nazir, yeah. Okay, great.
Set.
So, yeah, great. Thanks very much, Max.
Sure.
So I would like to introduce our next speaker, invite our next speaker, Professor Virendra Senha from Jaipur, a good friend, doing a lot of work on neurotrauma care in India, and now, of course, a lot of work on neuro rehabilitation, doing a lot of webinars on that. And he's going to talk about pre-hospital guidelines in lower and middle income countries. Senha?
Before we do that, maybe we should introduce Professor Basant Misra, who's joined us. Thank you very much, Basant, for gracing this CANS webinar. You're always supportive of Africa, and we're very, very thankful to you. And I'm sure Nasser would like to say the same.
Yes, I'd like to welcome our great Professor Basant Misra. Actually, I was honored to send him invitation, and I'm glad that he gave us much of some of his time today. I know that he's very busy, but he accepted our invitation, and now he's joining this event, and I will be happy that he will share in the discussion. Thank you, Basant, very much, actually. Thank you.
So, I'm sharing my screen. Okay. First, I want to thank Dr. Nasser, my great friend, Dr. Tariq Khan, for inviting me for this webinar. I'm honored by joining this webinar. My topic of presentation is pre-hospital guidelines in low and middle income countries. If we see the neurosurgical problems, it constitutes 1.7% of all the cases. And in neurosurgical problems, the trauma constitute, we know, 40%, and after trauma comes this strokes that constitute 33%, and then tumors, and then so many other diseases comes. So trauma is a very important part of the neurosurgical diseases. If we have not checked the road traffic accident as per WHO, it will be fifth leading cause of that by 2030. We know in the trauma system, from resuscitation to rehabilitation, the 4 stages: pre-hospital care, in-hospital acute, in-hospital definite care, and rehabilitation. Very important is this pre-hospital care. And it was compared from Western world, US and India. There were 3 times more mortality in India because of absence of pre-hospital care and delay in the admission. So pre-hospital care is backbone of emergency medical services, where because the secondary brain injury can be reduced with appropriate and expeditious intervention performed in pre-hospital phase. And it is seen that 20% of patients, they die because they don't get proper pre-hospital care. There is why pre-hospital care is important, because we have seen in few cities of our India that where good care has been given, 90% of mortality has reduced to 40%. And pre-hospital care is definitely increasing. That's why it's causing better results nowadays. Pre-hospital care also facilitated timely give the medical and surgical intervention. As far as the burden of the trauma is concerned, it is increasing because of the motorization, industrialization, migration, and changing values of the system. After trauma, either there is instant death or disability. So we must do something for this. The current understanding of TBI in developing countries is very limited because good quality population based information they are lacking, which are available in high income countries. And whatever information we get, it is from police or individual institute, which is not sufficient to understand the trauma. In India, from our National Institute, it was seen that 60% of the deaths are seen because of the brain injury after the trauma. And who is affected by the trauma? It is a young population or young generation, which is very important part of the society, which also proved from our big studies of EDH and SDH. And Bangalore, our National Institute also says that 72% of the death are from in 20 to 39 year of age group. So every effort should be made to improve the outcome. In our department also, we have proved that most susceptible age is 20 to 40 year in this series. As far as the pattern of the TBI is concerned, just same all over the world, 60% mild injuries, 20% moderate, and 15 to 20% of the severe injuries. As for Western literature, 1/4 injuries associated with the multiple trauma, but in our institute, only 10% of cases associated with the multiple trauma. Now we come to the pre-hospital care system. If we see the developing countries, there is no organization pattern in most of the countries, while in the Western countries, the basic life support, ELS MS or DOC ELS EMS system, where doctor team escort the patient, is very well developed. So our objective is to develop proper guidelines to establish standardized care across India or any developing countries. So all the patients who sustain neurotrauma sustain similar care. India is not only has diversity in the geographical terrains, language or landscape, but also patient care. There are few centers which has excellent management or patient care, but in the rural area or other areas, we are still lacking very good care. Now, I want to share few of the Asian countries. Take Thailand. In Thailand, there is insufficient pre-hospital services which make difficult patients safely to hospital, and improvement in EMS is critical component of transportation infrastructure. Now come to Indonesia, which has 1,600 islands, very difficult geographical condition. Hospitals of varying standards are widespread. They don't have any system of emergency ambulance or patient retrieval. 118 ambulance is available only few metro cities. Now we come to our neighboring country, Pakistan, and which is also an other country is Latin America, which is also developing. But in Latin America, because of increasing training in form of PSTLS, the pre-hospital care has shown very good results. While in Pakistan, they don't have any means of transportation and still not very good care. Now we come to Nepal. Nepal is again a country of very adverse this climate and very hilly places. So approximately 70% of patients are transported by old transport system to road to a road. Next, come to Malaysia. That is also a developing country, It's a very small country, but because recent development in interest of emergency medicine and training program, they have improved the EMS and pre-hospital care. Just I want to share experience of Taipei. I witnessed experience at 11 a.m. and patient was transported to hospital at 11:20 in front of me. So this is excellent. If we see in India, 24% patient only they go to hospital in golden hour. Why we talk or discuss about the platinum hour, and 20% of the patient they don't reach to hospital even 24 hours. So pre-hospital assessment and treatment by first responders are very critical step in initiating the safe and appropriate care of the patient. And for this, we must target the police, traffic police, driver, taxi, bus, or truck drivers for this work. We have analyzed this who carry the patient to our hospital. In 830 patient, no patient was bring to our department with medical retrieval team. 83% of the patient they were transported by member of the public. So this is a neglected disease of modern developing nation. We must develop the guidelines for this to improve patient care. So the health professional work effectively to identify and prevent TBI. In this respect, we work with Dr. Jogi and Dr. Rajnan from US, and we developed the head injury trauma guidelines, which is going to publish soon, I think next month, and with our National Neurological Society of India and National Neurotrauma Society of India. We know that impact of injury causing neural cell death and irreversible brain death damage can be prevented and reduced. And TBI, we know cause lot of lifelong disabilities and burden on the family and countries, and lot of financial burden of the families and countries is they are losing for this rehabilitation only. So we must develop evidence-based guidelines, which are very important, which reduce practice variation by increase efficiency of healthcare. They align clinical practice with the evidence so they reduce use of ineffective and harmful therapies, increase use of ineffective therapies, and finally improve patient outcome. Significantly, we have seen that they decrease the mortality and disability, which is very well proved by USA. These guidelines, when they are using, they decrease the mortality from this 51% to 20% currently. So these guidelines also cause systemic approach, which lead to rapid and accurate diagnosis. But unfortunately, there is very little publication in this regard in India or in developing countries. So we have made a guidelines. We reviewed the US and European experience guidelines. We assess the current situation in India. We have created the guidelines which are practical and applicable to the India, and we get by few information from the various agencies like fire, then schools and number of places about this improvement, and we create these courses for different providers, and we also develop excellence of trauma center in India, in Chennai also, so which is working very nicely. And but most important part, these guidelines for application, our government support. So the goal of TBI prevention, management, and rehabilitation are to ensure injury do not occur in first place of majority, as TBI are preventable and predictable. For this, awareness is very important for prevention. which can be done by increasing public awareness program. Program should be focused on increasing safety, informing local enforcement agency to implement road safety programs, and joint plan of action should be developed at the state level and must be implemented across the cities, especially in rural areas. Now rural areas have more problems of road traffic accident. So, and we must use the stakeholder, including media, celebrities, public figures, and others. So, we know that prevention of secondary insult is very important because brain resuscitation should be started at earliest in traumatized brain, which is very susceptible to hypoxia and ischemia. If not taken care, then it will go continue unchecked. For this, SOS telephone, highway patrolling, and emergency ambulances are important. So we have most of the highways in India. We have this monitoring system, SOS, and this all basics to help the accident victims. Awareness program, we are, as I told, most of the people or patients are coming from rural area background nowadays. So for awareness program, we have selected family member or accident victim for awareness program, and schools, police, NGOs, we are training, taking their help for awareness program, audiovisual, celebrities, and in our city, we have put at number of places signboard and hoarding about the awareness program, and they help definitely. And especially we work for helmet and advocacy, and that's decrease the mortality from 42% to 21% in our city. So this just I want to share our efforts for awareness program for school, and we also doing rallies time to time. So he's Dr. Michael, and as I told, we use the patient themselves for giving good message about the awareness program, and number of times we are having the rallies for awareness program, and Professor Teasdale was also invited to flag off this rally in our city. Our Neurological Society of India engage celebrities because celebrities are very important for awareness program, and the people follow their words. So then newspaper, because every person reads newspaper in the morning, so they are very good media for this awareness program. So we need a national campaign which based on American first there, first care. So stop to help, call for help, assist the victim, start the victim breathing, and stop the bleeding. And every vehicle must have first aid kit, and it should be made compulsory. Current communication system India or in developing countries, we have number of phone call systems, which is very difficult to remember. So all across the country, we must have one uniform emergency number, and there should be a good coordination between the EMS team and designated hospital staff. For this, we need a proper training, repeated mock exercises, which could enable faster and well-coordinated services. So nowadays, as Dr. Russell told, the new system like GPS, mobile, and different techniques can be used for this. And we can use the police, fire, arms, Red Cross systems for this even this first responders. But the most important system is central monitoring system to monitor the activity of the first responder, EMS staff, and various hospitals. So we must give stress on the education of EMS staff as well, and this should be 10+2 because their background education is very important. What should be the quality of EMS staff? They should dispatch the patient to highest level of care and EMS provider from the scene. They must be highly skilled to know the exact mechanism of trauma, determining the GCS, assessing the vitals, performing the pupillary examination, and they must know about the fluid resuscitation and airway management, and must be considered when choosing a hospital to which the patient will be transported. So there are three critical tasks for individual victim. Examination is very and recognition of severe injury is very important. If there is a multiple victim, triage is very important, and stabilization and transport to a hospital capable of addressing the identified injury is very important. We must have more of the ambulances systems, and all ambulances must have uniform system of equipment, medicine, etc. And annual certification of instrument and vehicle should be there. So, but if we see the present situation in India, uh, we live in 2 centuries. This is the metro city. This is still we see in the rural areas. Why this is so? Because there is a lack of appropriate vehicles, absence or inadequate roads, and inability to pay transport services. But nowadays we have 108 ambulance services throughout our India, most of the part, very working very efficiently, and they are reaching within 20 to 30 minutes to the patient, and definitely improve the pre-hospital care and patient management. So the knowledge of ability of multi-specialty facility must be there. Hospital must be verified and designated for various kinds of emergency, and real data of ability of team at hospital should be known to EMS through central monitoring system, which regulation of unnecessary effort should be avoided, and clear and well comprehensive clear clinical guidelines should be made or available. I don't want to go in details. The EMS staff must know the primary assessment, secondary assessment, and all whatever they have assessed must communicate to the designated hospital. Airway support, indication of intubation should not be done by until there is a very skilled staff is there. And but in our state, we have provided the laryngeal mask airways, which success rate is 81% compared to endotracheal intubation 57%, and patients are very much helped by this laryngeal mask airway. This then oxygenation, blood pressure monitoring, GCS, GCS in pediatrics is very important. Then fluid resuscitation. We usually use only isotonic saline, but hypertonic saline resuscitation is definitely a better option. Then we should not use the ventilator or intubation, as I told before, until the very skilled medical team is escorting the patient. Just I want to share our effort in our state. I stay in Jaipur. We have 5 highways from our city. So we identify the area of accidents or accident zone areas, and the person who stay most of the time in that area, like shopkeeper, social worker, teachers, police. So we train all the staff about the first aid. And so because the person who is staying on the highways, they don't have any knowledge of immobilization, position, or prevention of aspiration. So we must teach them, and we have educated on most of the highways of these people, and we are getting early transfer of the patient nowadays. So this is our, we have also established the first aid post on few highways. So when there is a head injury or accident, people report to first aid post. They have the first aid kits, so they help for first aid and sending the patient to the hospital. This is our few of efforts I'm showing you, and most of the time we train the pre-hospital care to pilots of all the ambulance. This is our regular feature in our state because they are the person nowadays transporting most of the patient from rural area or urban area to our hospital. So to conclude my talk, I want to tell that correct identification of TBI is important. Optimal treatment in ambulance should be started. Direct transfer to a TBI trauma center or appropriate center should be done. Whatever we do, it should be optimal, prompt, and cost-effective care for the patient. Thank you very much.
Thank you very much, Professor Virendra Sanhi, for this great talk. And actually, I'm always saying, and I totally believe that neurorehabilitation is very crucial while dealing with our neurotrauma patients, and it's indispensable. I can also say that this specialty needs to be developed in the developing countries and in sub-Saharan Africa, because actually we don't have much of these neurorehabilitation centers in our countries. That is something which will be going to be discussed. I think now I'm pleased first to just take a few minutes to have, we have two questions over the panel, and I'm happy to introduce Professor Quintana. I hope that he is still joining us and he would like to say some comments. He is well known and he is honorary president of the World Federation of Neurosurgical Societies. Quintana, can you hear me?
Yes. Thank you, Nasser. Thank you to all this excellent symposium. I can see here my friend Russell Andrews, Terry Khan, excellent panel. So as I said to you, I want to learn from you. I have treated especially the rescue of severe neurotrauma cases in cases of disaster and emergency. As you know, Chile is top 10 in disasters, tsunamis and earthquake. And in that situations, I have treated this kind of treatment just in the site of the emergency with Professor Russell Andrews and Tariq Khan. In many meetings, we meet in World Federation meetings and so on. But here I want to share the experience with big conferences as you, and the conference of Professor Virendra Senior, I think is excellent. So thank you for giving the opportunity to share this experience with you. Thank you.
Thank you very much. I don't know, Basant, are you joining with us until the end of the webinar? We still have one speaker because we wanted to open discussion.
No, I'm
okay.
there.
Thank you very much. Now we have two questions over the panel. A question from Morocco. George, I already unmuted your mic. And another question from Egypt, Mariam Ghanem, I already unmuted your mic. Would you introduce yourself and say your questions, please, if anybody would hear me?
Yes, Dr. Nasser.
Yes, Mariam, go ahead, please. Yes.
I am Mariam Ghanem, a neurosurgery specialist from Al-Azhar University, Egypt. Thank you for this eminent lectures from my professors. I would ask about first lecture, the inflammatory cascade of traumatic stage of trauma. What I understand that the inflammatory cascade is responsible for the insult or the severity of insult of the trauma. So hypothermia can minimize this insult or reverse. This is right. We can use hypothermia for minimizing the inflammatory cascade, so we can prevent the post-traumatic sequelae as we can. This is what I understand. This is right or not?
Okay, Mariam, you asking Professor.
This is the first, yes, there is the first question.
You are asking Professor Andrews or Professor Iku?
First lecture.
Professor Russell.
Professor Andrew.
Okay, Professor Andrew Russell.
Yes.
Professor Andrew, can you hear me?
I'm not sure I got that question. Could you?
She's asking about the role of hypothermia, if it plays any role in decreasing or minimizing the inflammatory cascade in neurotrauma patients.
Well, I think Professor Eco addressed that. I think there's mixed evidence on that. You have to do it very carefully. I think there are some very interesting manipulations that are on the horizon for adjusting neuroinflammation response. Some of it can be favorable, especially the more delayed microglia and macroglia responses can be actually restorative. And so one area that I've got an interest in, and there's work going on, is the use of nanoparticles to optimize, reduce the pro-inflammatory early inflammation and emphasize or increase the anti-inflammatory later response. Another topic is related to that, I think, is the use of stem cells in neuro repair. And again, the data have not been very good so far, but I think again was looking at augmentative techniques with exosomes and nanoparticles. We may see a real difference in the benefit from stem cell treatments for neuro repair over the next decade.
Thank you very much, Mariam.
Thank you, Doctor. Yes, another question.
Professor Eco would want to address hypothermia more specifically.
Thank you, Mariam. Yes, okay. Thank you, ma'am. Thank you. Yes, in my studies, we use hypothermia in marked hypothermia. We use 34 and 36 centigrade. That's it's important for us to protect the side effect like chill and others. So we use until now with research on concentrate in MBP9 and we evaluation with CT Marshall and the classification of CT performance, I think. So until now, the result is a good result. Even in several studies, there is a Euro term. There's to decrease the mortality and to decrease intracranial pressures. But in other studies, it's still a controversy. It's not problem. This pro and controversy, we still need to explore further. But eventually, precisely, we use in selective cases, I think it's important for us.
Thank you, Iko. I know, Mariam, you have another question, but we make it after our last speaker. We will have open discussion and we will introduce you again, okay? And now I'm honored to introduce our last speaker, Professor Tariq Khan. He is Dean and Chairman of the Department of Neurosurgery at the Northwest School of Medicine, Peshawar, Pakistan. And he is chairman of the Neurotraumatology Committee of the World Federation of Neurosurgical Societies. He is going to speak about neurotrauma care in low and lower middle income countries.
Thank you. Can you see my screen, Nasser?
Yes, it's very good.
Oops. For some reason it's not moving. Yeah, okay. So I'm going to talk about a very important topic for the lower and middle income countries. Just to show you this old map, which the WFNS has got, it has been now re-improved, and it shows all the countries in red, which have got very few neurosurgical workforce, and you can see that a large number are the lower and middle income countries, and we know that we need more than 20,000 neurosurgeons for improving the neurosurgical services, and most of the neurosurgical people required are in the lower and middle income countries. We know that 74% of surgeries for TBI are needed in LMICs, and this is the surgeries required, not the surgeries done. We also know that 89% of surgeries for traumatic spine injuries occur in lower and middle income countries. So how to handle this large influx of trauma, brain and spine? It has to be, innovative and develop policies and to integrate ourselves into the health systems. So we need to get a holistic approach, starting from prevention, as was discussed by Sinha so aptly, and then ending with rehabilitation, as Professor Maiden discussed. So it's all inclusive. It's very important to look at all the aspects of neurotrauma. There was a survey conducted by us, Asian Australasian Society of Neurosurgery and Neurotrauma. Peter Riley was heading that, and we had hospitals from Indonesia, Jaipur, and from Peshawar. And we looked at the helmet and seatbelt use, and you can see that 7% of the patients were using helmets, and very small number, 13% were using seat belts. And you know that in our region, we try to get into the Guinness Book of Records. We have as many people on a motorbike, and we think that one helmet will protect everybody. So prevention, very important, the most important part. Prevention is better than cure, and we started this process back in the early 90s in Peshawar, and then we converted it into the rest of the country. And there were seminars held, poster competitions by students held, walks done. And then the Neurotrauma Committee of the WFNS joined hands with Think First International Injury Prevention Foundation. And we had our first public awareness seminar on prevention of brain and spine injuries in ICRA 2019 in Peshawar, where more than 1,000 people attended, and from all walks of life, and they were made aware regarding brain and spine injury prevention. Then who provided the emergency treatment at the scene of injury? And we looked at, again, it was the pedestrians or the lay people or the shopkeepers around. And then did a nurse or doctor accompany the patient? So in majority, it was nobody in the ambulance. In fact, most of the ambulances at that time neither had nurses, oxygen, or suction. So really, it was better to take them in a car rather than wait for an ambulance. We know that the phases of the injury, that 50% who die from TBI do so within 2 hours of injury, and 40% of pre-hospital deaths are potentially preventable. So in the high-income countries, there is a much lower rate of death, 59% in the field, and 72% in the lower and middle-income countries, 81% lower-income countries. So it's very important to transfer patients as quickly as possible. And if you look at the duration to surgery, again, it was sometimes more than 24 hours because of poor ambulance services or lack of roads or large distances. And we know that the management is geared towards prevention of secondary injuries and rehabilitation. And secondary injuries like hypoxia, hypotension, edema, raised ICP lead to increased mortality. So longer the delay, greater the mortality. And that is why training the ambulance staff and getting proper ambulance services going on is the most important aspect. And we are lucky that most of the governments now in the lower and middle income countries are looking to that and improving the ambulance services, the EMS, which is a very, very good thing. It is helping reduce the mortality. Then we need to have guidelines, and the guidelines is setting the minimal standards of care for the accident from the accident site. And we need to first agree on the minimal core guidelines, and it has to be a system of care which grows as trained personnel and resources become available. And the assessment has to be by the epidemiology of the trauma, and they have to look at the local resources, the profile of injury, the local data, geography, transport difficulties, resources, and protocols. As Professor Sinha was saying, that you cannot adopt or adapt any guidelines from anywhere in the world. You have to try and develop them for your own. And the Neurotrauma Committee of the WFNS requested Andres Rubiano and his team to look at how to develop these guidelines, and they gave these recommendations of the Colombian Consensus Committee for Management of Traumatic Brain Injury in Pre-Hospital, Emergency Department, Surgery, and Intensive Care, and it was called Bootstrap, Beyond One Option for Treatment of Traumatic Brain Injury, a stratified protocol, not a fixed protocol. So you need to look at this paper, it's very important. And we did a commentary on that, and which was on the paradigm shift from standard-driven protocols to resource-driven guidelines for neurotrauma management in lower and middle countries. So it's important to say that we know that if we don't have those standards, we need to have protocols according to our resources. So we cannot say that we cannot have guidelines because we don't have the those standards. No, we can have resource-driven guidelines and develop them slowly and improve on them. So that is very important. Now we know that the in-hospital management is guided by GCS monitoring, CT scan, ICP monitoring, pupillary response. And the goal is supportive treatment and prevention of secondary damage. The Brain Trauma Foundation guidelines are evidence-based guidelines, and they talk about general maneuvers, normothermia, sedation, volume replacement, and the first line is CSF drainage, hypocapnia, mannitol, 3% saline, and then the second tier is high-dose barbiturates, intense hyperventilation, increase in mean arterial pressure, hypothermia, and decompressive craniectomy. The Brain Trauma Foundation recommendations show that there's level 2A evidence that bifrontal decompressive craniectomy has been shown to reduce ICP and stay in ICU, but not the outcome extended score at 6 months. And also recommended that a large fronto-temporoparietal decompressive craniectomy, at least 12 by 15 centimeter, for reduced mortality and improved neurological outcome. This is very important. If you're going to do a decompressive craniectomy, it has to be large. Small DC will not help really. And there's level 2B evidence from ICP monitoring that it reduces hospital stay and 2-week post-injury mortality. And ICP should be monitored in all salvageable patients with GCS 3 to 8 after resuscitation with CT changes. Or ICP monitoring is indicated in severe TBI with normal CT, but having 2 or more features on admission, age greater than 40, unilateral bilateral motor posturing, or systolic blood pressure less than 90. So this is a high-end ICU, as you can see, and this is the ICU critical care in lower and middle income countries. So obviously, we're far away from what they're doing. So what are the guidelines for the lower and middle income countries? Majority of severe traumatic brain injury patients globally are managed without ICP monitoring. There's no recent literature to guide management in non-monitored patients. A large part of literature comes from well-equipped, larger centers in higher income countries. There are no resource-based guidelines in LMIC to guide surgical severe TBI management. So you may all know about the BEST TRIP trial 2012 by Randy Chestnut, who provides the only tested non-ICP monitored treatment protocol. And this trial had a lot of critique, but it found no evidence of outcome difference for monitored and non-monitored patients. And this trial compared ICP monitored patients versus non-monitored, that is clinical examination and imaging, which is the ICE protocol. This was further improved and it was developed into a consensus-based management protocol, CREVICE, for the treatment of severe traumatic brain injury based on imaging and clinical examination or use when ICP monitoring is not employed. It's not a substitute for empirical evidence. It's an effort to provide for the vacuum left by absence of evidence-based guidelines. So just to let you know what we are doing in Peshawar. So some patients, we go straight for decompressive craniectomy on admission. Some patients where we don't go for a decompressive craniectomy on admission, we would like to do ICP monitoring through an intraventricular catheter, if it is possible to place it, and then treat it accordingly. And then the third is the CREVICE protocol. So our indications for decompressive craniectomy in trauma are when the CT scan findings show diffuse brain edema, with or without brain contusions and subdural hematoma, effacement of basal cisterns and ventricles, midline shift, GCS of 9 to 12 or a drop of 2 degrees from previous, and age less than 70, or 70 there is a 75% mortality. I'm not too sure about that now as I'm growing older. I wonder whether this age should be taken up to 80. Refractory intracranial pressure. How do we manage? You all know how to manage if you have got an ICP monitor, you give boluses of mannitol and saline, and then depending on all that, according to the Brain Trauma Foundation. So how is the management done with the Cree-Weiss protocol? So the Marshall score on CT scan brain is used, interval CT scans are done, clinical scoring GCS neuroworsening is looked at, pupillary response is seen, and then there's a 4-tiered management response. So basically, you score on the CT brain, and then you, every 24 hours, you stop the sedation, you look clinically at the patient, and then repeat the CT scan, and then depending on that, you go further. Just for the young neurosurgeons, to give you an idea of the Marshall grading, it depends on the cisterns, the midline shift, and a mass lesion. So intracranial hypertension is suspected and treatment is recommended in the presence of 1 major or 2 minor criteria. And the major criteria are compressed cisterns according to the Marshall diffuse injury score, midline shift greater than 5 millimeter, non-evacuated mass lesion, and minor criteria GCS motor score of 4 or less, pupillary asymmetry, abnormal pupillary activity, and CT classification of Marshall diffuse injury, that. And the neuro worsening is looked at as a decrease in the motor GCS of 1 or more, points new loss of pupillary activity, interval development of pupillary symmetry of greater than 2 millimeter or bilateral mydriasis, new focal motor deficit, and herniation syndrome. And the imaging schedule is initial imaging, then repeat at about 12 hours, if initially scanned done at less than 4 hours, then at 24 hours, 48 hours, and then as required. And the tier 1 therapy is hypertonic saline, scheduled mannitol, maintain normothermia. Tier 2 is hyperventilation, hypertonic saline, increase in sedation. And then tier 3 is decompressive craniectomy, high dose barbiturates, hypothermia, which are something which may be controversial at times. And then untested protocols as hyperventilation, hypothermia, and nimodipine and magnesium. So you escalate the tiered therapy, adding another treatment. If there is neuro worsening, if there's no improvement or worsening on follow-up CT imaging, or no acceptable response to the initial therapy. This is just the matrix. And then the decision support matrix depend on the Marshall score, pupils and motor response. And the idea is when to wean off the ventilator. And the green are when you can remove the ventilator. And the yellow is that plus minus, and red is that you cannot. And you can see in the first 24 hours and then 48 hours, you see that as time goes by, it is showing that you can maybe start weaning off the ventilator. So it shows us also how to and when to do a CT scan, when to do a decompressive craniectomy, when to start weaning off the ventilator. I believe this is a good plan, and maybe we should think of doing a study in the lower and middle income countries someday on this project. Just want to tell you that you have seen this this very important document, the consensus statement, role of decompressive craniotomy, the management of traumatic brain injury, which was grouped together in 2017. I think it's an important read. It will show you exactly how to do a decompressive craniotomy and when. This was the article which was published there. Then what Professor Max Maiden talked about, where are the patients discharged to? Most of them are discharged to home. It is rehabilitation, one of the most important part, and which is often neglected in developing countries due to poor resources. So what we have started doing, and there's been a nice paper also on it, that to train the family members in rehabilitation, and they can try and do it at home, at least if nothing else, skin care and tracheostomy care and these sort of things. In 2019 November, in the ICRAN meeting, we launched the comprehensive policy recommendations for head and spine injury care in lower and middle income countries. It was a collaborative effort from Howard Key Parks Group and from our Northwest School of Medicine. And this was basically a policy recommendation for policymakers to do that we wanted to ensure that we can have neurosurgical centers in different parts, and that at least 44 hours difference should be there. And the idea was to spread all this and be able to do something by year 2021 in Bogota. And what we were able to do is that when we were doing the provincial engagement workshop on the National Vision for Surgical Care in Peshawar, which we were hosting, we were able to piggyback neurotrauma onto the National Vision for Surgical Care. And this is the basically a National Surgical Obstetric and Anesthetic Plan for Pakistan, which was launched now last week. And we're the first country in Asia to have launched this surgical vision, and head injury, spine injury is part of that program. Global neurosurgery is a very important thing. In addition to doing neurosurgery better, how to better deliver neurosurgical care to all who need it. And that is why, and I must say here, I must commend and congratulate Professor Franco Sarvade, the president of the World Federation of Neurosurgical Societies, that during his tenure, a lot has been done really in doing a lot of innovative things, a lot of help for neurotrauma, a lot of help for lower and middle income countries. And this launching of the Global Neurosurgical Committee, which is headed by Key Park, and the objectives were to achieve universal access in neurosurgical care, to align and coordinate all global neurosurgery activity within WFNS, to stimulate and facilitate relevant research to inform policy, to engage with surgical stakeholders for building integrated surgical systems, to co-educate for investing in surgical care for all within universal health coverage by 2030. And as was discussed regarding the distances and whether we should train non-neurosurgeons or not, that's a lot of debate. It has become much easier, as Professor Russell Andrews showed, regarding that you can now use teleradiology for virtual surgical systems and guidelines for that. Thank you very much for your time.
Thank you very much, Professor Tariq Khan, for this very important presentation. And now I think it's time to have a discussion, to open discussion. Just first of all, we have three questions, and all of them, their mics are unmuted already. We have a question from Jose from Morocco. Jose, are you here?
Hello.
Hello.
I'm Dr. Uday.
Uday from India, you have a question as well. You would like to make a comment? Okay, please go ahead.
Sir, I want to ask...
Introduce yourself first and then say your comment.
Yes, good evening, sir. Am I audible, sir?
Okay.
Am I audible?
We can hear you, it's good. Just
sir,
introduce yourself.
Okay. I want to ask when to give 3%, when to give 23.4%, and when to give 7% normal saline in the pre-op or the post-op period to reduce edema. Is there any fixed protocol, or I mean, we should give on day 1, day 2, day 3? How should we progress with that?
Yes, thank you. I think 3% saline is the most commonly used one, and
yes,
it's mostly used in patients who are hypovolemic and patients in pediatric patients also. I believe that it may be more beneficial than using mannitol most of the time. But 3% saline, let alone 7% or 23%, are very difficult to find in lower and middle income countries. I do not have experience with 7% and 23%, but 3% is something which is routinely used and should be used, and can be used as often as required over the 40 to 72 hour period.
Okay. So my second question is what is the role of neuroprotective drugs in TBI like citicoline, paracetam, edaveron, or calcineurin inhibitors? Is there any justified role? Should we give them?
There are a lot of drugs available in
Yes.
different countries of different types. I personally, unless they are, and most of these drugs are really not tested, and I sometimes believe that maybe many of them are more used as a placebo rather than an actual use. But maybe Ego can tell us something on that aspect as well.
Yes, thank you. I agree with Professor Tariq, but it's a dependent pathway. The TBI have a multifactorial pathway, so it's difficult. We have to stop one pathway or three pathway. So we have presented with a book therapy how to inhibit with several pathway. It's important for us. Maybe citicoline only stop in inhibit one or three pathways. But in traumatic brain injury, especially in severe traumatic brain injury, there are many pathways. So we need a book therapy, how to stop all of the pathway. Thank you.
Thank you. Thank you, Uday from India. We have another question in the panel. Thank you very much. Hamid Al-Sanusi. Hamid, do you like to say your question directly or I read it? Are you here? If you are here, speak. Your mic is unmuted.
Yeah. Thank you very much for this. Yeah.
Okay, introduce yourself and then say your comment, please.
Yes, thank you very much. Do you hear me now?
Yes, it's very good.
Okay. Do you hear me now, sir?
Yes, we can hear you. Proceed.
Okay, thank you very much for this chance. My name is Hamid Sanosi, the national citizen, resident of neurosurgery. Asking about the effect of voltage stress as a moderator for transforming mechanical responses, mechanical stimuli, like mechanical trauma, into chemical and immunological responses. In cases of concussions, there is a rapid movement of the CSF inside its normal pathway. Okay, this will increase the wall shear stress on the brain tissues located inside this CSF. Accordingly, we notice changes following this concussion. My question is about are there any figures or studies done that made figures or estimations done to assess the ability of different types of cells placed inside the cranium and the proportionality to shear stress? Questions directed to Professor Eko. Thank you very much.
Okay. Professor Eko,
Dr. Hamid, it's really interrupted with your sound.
Okay, do you want me to say the question again?
Yes.
Okay. Hamid Al-Sanusi is asking about if there any role for the wall shear stress as moderator in transforming the mechanical stimuli into chemical and immunological response in cases of brain concussion.
Would you please pardon the sound, because in here is very heavy rain.
Yes. The role of wall shear stress as moderator in transforming the mechanical stimuli into chemical and immunological response as in cases of brain concussion.
The role of, what do you mean? The role of...
Sanusi, would you explain, would you clarify your question again, please?
Okay. Wall shear stress is the force per unit area applied by blood to the wall in the tangential direction. For example, if we have a turbulent flow inside a body, turbulent flow is contradictive to the normal laminar flow. Increase in the velocity of blood flow inside a body together with the increased viscosity, will change the wall shear stress. The response of the muscle will be increased wall shear stress into the endothelial cells. These endothelial cells will respond by releasing of chemical mediators, which will end as an aneurysm at the bifurcation of the muscle. The very same thing happens here when brain concussion takes place. So this will change the wall shear stress on different brain tissues as the CSF here moves in a different way, something similar to the turbulent blows inside the body. My question is that, is there any study done in this field? Are there any figures done or put to estimate the effect of wall shear stress on different brain tissues in cases of concussion?
No, we don't have yet. We don't have yet. No, we concentrated in NVU, in blood-brain barrier and ECM. And in this area, we have concentrate how to manage this area, because this area, there are many microglia, M1 and M2, and this is the entry point, our concentrate or our study. So in concussion, sometimes that's maybe mild traumatic brain injury. That's the opening of the basal membrane, and CSF is still normal limit. So we didn't use to explore in post concussion except in hyperbaric, because technical reasons. So we use post concussion syndrome to monitor with scale concussion syndrome. Except because technically reason we use a patient with mild TBI for hyperbaric, but normally in immunologic and biochemical study. So we in this area we still priority in NVU. Thank you.
Thank you, Eko. Another question from Morocco. I will say it: how trauma center should deal with polytrauma patients, and if there is any guidelines by the World Federation of Surgical Societies Committee. I think Professor Tariq, you can answer this question.
Yeah, well, there are no guidelines from the WFNS on this, but I believe triage is meant for this particular purpose. Yes. That if there is a multi-trauma, and I think Leo Quintano can tell you a little more about these, because they have been through a lot of earthquakes and they have been triaging these patients. So Leo, maybe you would like to comment something on this?
Professor Quintana, will you unmute your mic, please?
Yes. Excuse me, but Tariq, could you repeat the question?
Yeah.
Actually, I have another question related with the.
Yeah. So what they wanted to, the question is whether what are the guidelines for trying to deal with a disaster or multiple trauma patients, coming in. How do you do that?
Yes. Well, as you said, well, I want to compare phase 1, phase 2, as you mentioned, phase 3. In general, when we enter to the tier 3, when we have to decide more severe trauma cases, I have here, for instance, Franco Servadei. You remember him? We invited, we were in Indonesia, I don't remember. And some experience from Nepal colleagues. Do you remember? Before entering to the comprehensive craniotomy, they use cisternostomy, drainage of cerebrospinal fluid from the basal cister. At that time, that decision, that therapeutic decision, before entering to barbiturate coma or the comprehensive craniotomy on hypothermia. So they produce draining of the basal cistern, you know. So at that time, I remember 1916, well, was so much discussed. But recently, I hear again Franco Servadei, and he admits that this decision to produce a draining of the cerebrospinal fluid from the basal cistern is admissible, you know. So the decisions, even from the authority as Servadei, from the World Federation, are permitted, I think, because the difference, I have a lot of experience in vascular pathology. If you put brain trauma, severe brain trauma, against, for instance, infarction of malignant infarction of middle cerebral artery. In malignant infarction of middle cerebral artery, you don't have time. You don't have time to monitor intracranial pressure. So you must decide the therapeutic decision only by imaging, CT scan, and the clinic, the glaucoma scale. But in trauma case, you have time to insist and monitor the patient. That's very important. I think when Randall Chestnut decided he did an experience in Latin America, especially in Bolivia and Ecuador, and some conclusions he said, perhaps it's not necessary to monitor intracranial pressure. I think was very wrong, that decision. We should insist that the intracranial pressure, just when we enter to the tier 2 to tier 3, is very important to monitor intracranial pressure, as you said. So I think I don't know if I answered your question, but that evolution from tier 2 to tier 3 is very important. And I think intracranial pressure should be monitored anyway.
Thank you, Leo. Professor Basant Mishra, would you like to say comments?
Yeah, well, thank you, my friend Nasser. It's a pleasure and privilege to be associated with a very nice webinar with very, very important presentations. And from in our continent, the two giants of the trauma care, Tariq Khan, my good old friend for a very, very long time. We've got white hairs now, but we know each other from black hairs. And our young colleague, Virender Sinha, both are really pioneers in Virender is by the way, I don't know whether you introduce it, some people may not know, he is the chairman of our ASNS, our Continental Trauma Society, our group. And of course, Tariq is, we all know, he is the WFNS trauma chair. So we have two people who have doing tremendous work. And I just saw Tariq's presentation, the type of work they do, and Professor Quintana, again, good friend, saying about the ICP monitoring. You know, there is a slight difference between a Western country or a country with a lot of facilities and a country like mine or Pakistan like Tariq's. So Tariq had that consensus statement about, trying to do DC before sometimes ICP. You know, there are very many low and middle income countries. We said two procedures, doing an ICP is one procedure and then stay in the ICU, another long procedure, doing the monitoring, expensive, people can't afford it. So sometimes it's not practical. Ideally, ICP should be done. I trained with Douglas Miller about 40 years back, and every single case, we not only one, we used to have two systems. One was intraparenchymal system and one was subdural system. And we are comparing because Douglas Miller was one of the trauma pioneers. But having said that, I just, if you permit, Nazar, can I just share one slide? Is it possible?
Of course. Yes, of course, please.
Okay, let me see if I can open that one. See what Tariq talked about. We just published actually. Can you see my slide?
Yes, yes, it's very good.
Yeah, this is the publication last year, September. That is protocol-based early decompressive craniectomy in a resource-contained environment, a tertiary care hospital experience. This is our experience. My hospital, we have all the facilities, but the patients can't afford. That's the problem. There is no insurance in many large number of patients. They come in an emergency. So we actually concluded that if you see the conclusion, and this is again the Marshall score was actually published in 1984, just before they published. It was in January 1984 we published that this deterioration or the basal cisterns significance and obliteration is a very grave sign in CT scan. And so what we have done in our practice, we did an institutional review of DC from a tertiary center like ours is a unique way, in a way, as the results reflect in a descriptive way how decompressive craniotomy is used in real life in lower and middle income countries. Protocols-based early decompression without preoperative ICP monitoring in resource-constrained environment may be way forward. So very similar to, I mean, obviously Pakistan and India, they are similar situation we are in. So there is some role, I think that practically there is some role of having to do a decompressive craniotomy without ICP monitoring because of the constraints. You know, you go twice to the theater, not possible. Repeated MRI, CT scan, not possible. ICP facility not available in many countries. So to avoid the damage, you can, there's clinical based, the Marshall score, the GCS, the Dittorian pupillary sign, and so on. Like he gave a very nice talk, and we have almost similar independently. This is a 10-year study, and we had very good results. So that is one aspect. The second aspect between the developed countries and lower middle income countries, the type of injury is different. Like Dr. Sinha talked about, it is a very large number of two-wheeler accidents, which doesn't, I mean, the low velocity injuries, unlike in the developed countries, Western countries, very high speed injuries. So the type of injuries are different. So a protection, the prevention, you know, helmet goes a long way. We studied it in 1984. In fact, in Indian standard of helmet was based on my study in 1984, which we published. And like Dr. Tariq showed it, one person using a helmet and 4 people sitting on a two-wheeler. And it's not uncommon. Very commonly, the people have the helmet, but they hold it on the side. They don't put it on the head. They just keep it when the policeman, they see, they put it on the head. I don't know for what. I mean, they just impossible to kind of, that kind of thing. So slight difference, the social impact. And so you have to education like what Dr. Sinha talked about it. And Dr. Sinha actually has been tremendous work also in India and in our continent and other places. In fact, 2019, we had a continental meeting, which I organized, and he did, and which is done by our National Society. Every year, we have a public lecture. And 2019, Dr. Sinha arranged a public, very, very successful. The large number of people came and we kind of educated them, and he continues to do that. So tremendous work. And thank you very much for this opportunity. Great talks.
Thank you very much, Professor Basant Misra, for these very, very important and valuable comments. Now I'd like to hear opinion of Professor Mahmoud Qureshi and the experience in sub-Saharan Africa.
Thank you very much. I was listening to both Tariq and Basant, and they make very valid points. What we don't want the young neurosurgeons on this participant group to take away is that there is a two-tier way of managing head trauma. I think we need to enlist some kind of debate and merge the two and say, when there are adequate facilities, this is appropriate, but when there aren't the appropriate facilities, it's not like you then ignore doing anything, but this is a justifiable, and then show that, as Basant has shown in this paper, that it is a valuable approach to take, so that it becomes a composite recommendation from some group like the WFNS Neurotrauma Committee to say, in an ideal setting, when the facilities are available, even in our country here in Kenya, there are two hospitals that are well known for very high-class management, but that does not equate to the rest of the country. So even in our modest settings, such as East Africa, we will be able to do some of those very tier one recommendations and say, this is what we want to do. But it is justified when you do not have this in a peripheral setting to be able to do that, because the young neurosurgeon who is working in a peripheral setting would like to feel the comfort of support from the World Federation Committee that I'm not doing a bad thing, I'm doing the right thing, and it is shown up by studies such as Basant has outlined. So I think it's a very valuable webinar, and I really can't thank you enough, because what we have here is a snapshot of a potpourri of high-end management, but mixed with the low and middle income country experiences. And what I'm trying to suggest is that there should be a way to merge them to our Global World Federation Committee, so that the young neurosurgeons begin to feel that, yes, we're doing the right thing, even if we do not. It's like clipping an aneurysm. Yes, I'm happy to clip an aneurysm because I do not have the facility to refer this patient for endovascular treatment. So the patient should not say, I was given second-class treatment. It all becomes justified. My next point would be to echo, and again, a very, very illuminating talk, very detailed science, but that's what we want in this kind of participation, so the young neurosurgeons and trainees see the way forward and move towards your way of thinking. My question to you was, do you see at some point the development of biological markers in instances of head trauma, where we can say, you know, this one, we can do all we want, unless we get these biomarkers reduced by our strategies, we're not going to win in this particular case. Do you foresee that happening, both from a neuroprotective point of view, but also from the neuroplasticity point of view, that if we block these biological markers, are we going to enhance the neuroplasticity and therefore enhance the chances of a good outcome? I'd like to hear your thoughts on that. You're muted, I think.
Yes, thank you, sir. That's important for us. So the biomolecular, that's important how to inhibit, because some biomolecular protein, usually in area NVU, there is a pro and anti-inflammation. That's why we have selected how to control pro-inflammatory, because they are like microglia. They have a M1 and M2 is produced with a special character of the protein. So sometimes it's difficult how to control this positive and negative support of neuroinflammation. So neuropharmacology, that's difficult how to cut the pro-inflammatory, but sometimes anti-inflammatory also decreases. There's sometimes like interleukin 10, interleukin 6, like bridging, but sometimes all of interleukin 6 and interleukin 10 also decrease. This depends on the structures of the whole of the brain, and also the grade of GCS. In severe traumatic brain injury, sometimes it's not like the theory of biomolecular, like bridging, pro-inflammatory up and down, anti-inflammatory, but sometimes not like that. This is sometimes all of the pro-inflammatory decrease and anti-inflammatory decrease. That's why we difficult if we use neuropharmacology on reset. That's as I said, there is many lack of power. So I have suggest how to press this process with the book therapy. The book therapy like hyperbaric, like hypothermia. This is for further our research. Thank you.
Thank you very much.
So-
Thank you.
May
Mr.
I?
Tariq Khan.
Yeah. Thank you, Moody, for your comments. Just want to make 2 points rather. One is about the markers. You know,
Yes.
Andrew Maas and his group
Yeah.
did a very big study, Central TBI, and they looked at a large number of markers which they felt may be important in looking at the type of injury and looking at the recovery of the brain on that. The
Yes.
second point which I wanted to make was that is why, as you suggested, that the young neurosurgeons should not get this into their minds that this is the only way or that is the only way. That is why we requested, the Neurotrauma Committee requested Andres Rubiano and his group to develop these stratified guidelines for neurotrauma care, that we know that we have a golden guideline, European standards or even American standards, and that we should not say that we can't have guidelines because we can't reach those levels. We said, let's have a stratified thing, and then we wrote the commentary on that regarding that it should be resource-driven guidelines rather than the other way. So with the resources, as you pointed out, you have some very good hospitals, same as in many lower income countries, some very good hospitals, and then some very normal hospitals. So the good hospitals have got the best of care, but that does not mean that the low setting hospitals cannot give care. They can give care, and as you said, it is the appropriate care and can give as good results as the high-end care, definitely. So the young users must realize that there are different ways of doing it, different points, levels to achieve. But I thank you very much, Moody, for pointing this out.
Thank you, Professor.
I want to ask one. There's one discussion. So, like,
Yes, please ask.
So, decompressive craniotomy lowers the ICP immediately, whereas if you do a craniotomy and hematoma evacuation, it tends to lower the ICP a bit slowly, but works better on the cerebral perfusion pressure. So, I want to ask, if after doing a decompressive craniotomy, should we lower the head after 1 or 2 days, because that will work better in the favor of cerebral perfusion, because we have already removed the bone flap and ICP is lowered down, or we should keep the head up but that will work less in the favor of cerebral perfusion pressure.
Yeah, a very, very good point. I think if you have done a decompressive craniectomy, you can have the head in neutral also. It should not really be. Putting the head down is not really a thing. You can put it back in neutral. Yeah.
Thank you.
I think 30 degrees adequate. That gives the maximum perfusion, and results are compared with 30 degree, the best result for perfusion.
I think
30
we do 30 degree because the venous return is better with a little bit of high. So that is our protocol. And there are a couple of things which I just want to comment. Nasser, can I make a comment here?
Yes, please, Basant, go ahead.
There is another problem, like I said, in my hospital, we have everything, including the Camino and the intra, but patients cannot afford it. It's not only the resource available in the hospital. We don't have insurance, and 70% people come paid from their pocket. So difficult. So I think Dr. Sarvadi, the president, has been very, very involved in this. He only quoted that in some countries in Africa, they can't do more than one CT scan or even just one CT scan, and that's about it. No follow-up is possible. Same in my country, in some places, they're just not available. So they go for primary decompressive craniotomy. And by the way, Tariq, you should come out with some nomenclature. There is, in the decompressive craniotomy, you have a primary and secondary type. All are associated with an operation. There is no term, there is a confusion about primarily doing decompressive craniotomy without a hematoma just to reduce the ICP without raised ICP. You know, this clinical oriented decompressive care, there is nothing like that. It's a primary decompressive craniotomy with hematoma, secondary decompressive craniotomy after tire therapy fails. So what do you call the decompressive craniotomy, which is done not for ICP, which done without ICP monitoring, and when you are not evacuating the hematoma? That is one term which is missing in the
I
literature.
suppose one could say preemptive rather than primary.
So that is one. And the second thing, which is unique in countries like mine or Bangladesh or Pakistan, I don't know, maybe also Kenya or some parts of Africa, is the density of the population, the traffic. Now, in metros, we have very good, like Dr. Sinha said, we have 108 ambulance, you call it, but the ambulance cannot reach the hospital. Unfortunately, there is no special lane. You know, when I was working in UK, we get to know that the patient is coming and everything is red and only the ambulance can travel. All traffic stop when the ambulance going. You just can't travel in the ambulance in Mumbai. That's a unique problem again. So pre-hospital, the ambulance to be provided by paramedics is critical to save some of these patients. Thank you.
Thank you, Basant, for raising such a very important point because time is very important in these patients. Professor Tariq, I give the mic back to you again if you would like to say any more comments.
No, thank you very much. I think it was an excellent webinar, an excellent collection of people. Nasser, I congratulate you again, you and your team. I would like to thank all the speakers. I think we went right from one end, from prevention to the rehabilitation aspect and to the futuristic points as well, and to the molecular level. In every way, we have gone there today. And it was a great meeting, and I saw many old friends after quite some time now as well. So thank you very much, everybody, for joining in. Thank you.
Thank you, Tariq. And I would like to just say that much had been done for neurotraumatology patients by both your committees, whether neurotrauma or rehabilitation, but still we need much to be done. We have definitely a problem in the developing countries and in our continent, in sub-Saharan Africa. There is lack of guidelines and protocol of treatments in most of the centers. There is lack of ICP monitoring. There is definitely problem in ambulance, like Basant Mishra have just said now. We lack the presence of rehabilitation centers. And so still much work had to be done. And this collaboration is very important for the future. And all these facts, in spite that we all know that the majority of neurotraumatology patients exist in the developing countries and exist in the African continent. And actually, it was very successful webinar discussing a global neurosurgical problem, which is neurotraumatology or TBI, and focusing on low and middle income countries. And that's very important. At the end of this webinar, I would like to thank Professor Tariq Khan, Chairman of the Neurotraumatology Committee of the World Federation of Neurosurgical Societies, for supporting the organization of this important event. And actually, I'm glad about this very important collaboration. I would like to thank all our distinguished speakers for contributing to this event. I would like to thank Professor Basant Mishra and Professor Leo Quintana for their contribution and for their valuable comments. I would like to thank Professor Mahmoud Khorashi for joining us. May I not forget to thank organizing team, Mr. Ahmed Magdi and Dr. Hassan Ala, for the great job they are doing with me in organizing this webinar series. I would like to remind all participants that our next webinar, 48, will take place on Saturday, next Saturday, not Friday, because of the vacations existing in many countries. And as exception, we moved this webinar to be in Saturday, and it will be done at the regular time, 12 p.m. GMT. Thanks to all participants. Thanks to all of you. Hope to see you soon again in another occasion. Thank you very much.
Thank you. Bye-bye.
Thank you. Thank you.
Thank you.
you.